Okay, good afternoon, everyone. So it's 5 minutes past the hour, so I think we'll get started. So welcome to Cardiology Round. So today we have Dr. Muizz Wahid, second-year cardiology resident, who will be presenting on an important topic, management of heart failure with improved ejection fraction, and the title of his presentation is Ejection Fraction Recovered, Now What? Thanks, Muizz.
All right. Okay, so thanks for having me. We can get started. All right, so just in terms of the outline of our presentation, we'll talk about some definitions and epidemiology, the clinical significance and trials related to heart failure with improved ejection fraction, and then looking at some imaging and biomarkers, GDMT controversies, risk stratification, looking at ICD and specific causes of heart failure and what we do in those situations when our ejection fraction is improved, as well as ongoing trials. And then finally, we'll have a little bit of discussion on sort of what to do moving forward. So with regards to the definition of heart failure with improved ejection fraction, or HFimpEF, which isn't as easy to say as I guess as HFrEF. The baseline ejection fraction needs to be less than 40%, and there needs to be an improvement of greater than or equal to 10% to over 40%. Now, the 2022 ACC and AHA heart failure guidelines did recognize this as a distinct category, but really as patients with recovered EF, though they still have an ongoing heart failure history. Now, in the case of heart failure with improved EF, improved does not necessarily mean normal. As mentioned, their ejection fraction simply has to be over 40% with that incremental increase, but many of these patients still have an EF that's less than 50%. And of course, they do have to have a documented low EF in the past, so in that HFrEF range with later improvement, either due to clinical treatment or treatment of any other underlying cause. Going through the epidemiology, substantial subset of HFrEF patients do tend to convert to this improved EF demographic over time. However, the incidence can vary depending on the study. So generally, when we look at studies, around 10 to 30% in many cohorts do improve their ejection fraction. But depending on how different studies define heart failure with improved EF, and dependent on the duration of follow-up, this can exceed 50 to 60% in some of these cases. The rise in prevalence is largely due to better therapy. So this includes better GDMT, CRT, as well as management of underlying causes. So whether that's revascularization for ischemic heart disease and control of tachyarrhythmias, for example, with better ablation therapies. And again, the definitions varying across studies do portend this difference in incidence. Now, this was a figure from a review article by Kudur and Tang, which was just recently published in April in JACC, which is a very good review on heart failure with improved EF. This essentially looks at why or how the estimates of heart failure with improved EF can differ. So for example, some analyses may find that around 20% of HFrEF patients improve to greater than 50% ejection fraction after a year of optimal therapy, whereas another study with looser criteria, for example, defining improved EF as greater than 40% as opposed to greater than 50% might report 30% or higher. One thing to note that is with longer follow-up, there does seem to be a higher incidence of improving ejection fraction over time. In terms of prognosis of these patients, so they do tend to have better prognosis and better outcomes than those who do remain in HFrEF, which intuitively makes sense. LVEF improvement has also been shown to have associated lower mortality and hospitalization rates. And essentially, even partial recovery of ejection fraction does have some outcome benefits. Despite all of this, however, they are not risk-free. And as we mentioned earlier, these patients' heart are not entirely normal. There does still remain a persistent risk of relapse or decline of ejection fraction, as well as adverse events, which can be heart failure exacerbations and hospitalizations or arrhythmias in some patients. Because of this, a proportion of these improved EF patients do behave more like remission rather than cured cardiomyopathy. A lot of this due to the underlying myocardial abnormalities and neurohormonal activation persisting over time. Again, this figure from the same paper looks at reported estimated incidence of LVEF relapse among patients with heart failure with improved EF across different studies. These are largely retrospective studies with one prospective study. Again, looking at patients with heart failure with improved EF and then following them between 1 to 7 years. There really was no real intervention aside from simply being largely observational, and studies largely identified these patients and with typical management determined the rates of relapse as well as any clinical predictors such as atrial fibrillation and initial lower ejection fraction, sex, and etiology. And again, these varied by different studies depending on their inclusion criteria, their baseline demographics, and their population. These are just some of the studies that they looked at. And again, largely retrospective, one prospective, but no real intervention. So we'll look at one of our more cited studies in the field, TREAD-HF. So this was a study that was published in 2019 and appears to be what a lot of our sort of recommendations are based on. It was a pilot trial, a very small study that essentially investigated the withdrawal of heart failure medications in patients with recovered dilated cardiomyopathy. The study was small, so really it was 51 patients with prior HFrEF, which is defined as an EF of less than 40%, that improved to an ejection fraction of greater than 50% on goal-directed medical therapy that was sustained for more than or equal to 6 months. All of these patients were NYHA1, had a normal cardiac size and an initial low NT-proBNP of less than 250. Essentially, this was a best case recovered cohort. The design of the study was open label, randomized, where one group had stepwise withdrawal of essentially all GDMT over a maximum of 16 weeks. These included beta blockers, ACE inhibitors, ARBs, MRA, and any others. A second group continued GDMT during this time. After 6 months in the continuation group, so the group that continued GDMT, they also had a withdrawal of GDMT by the same method to increase the power of the study. And then the primary outcome was essentially relapse of heart failure. They defined the relapse of heart failure as any of a greater than 10% drop in ejection fraction to less than 50%, an increase in LV volumes of greater than 10%, or greater than 2 times rise in NT-proBNP or any clinical signs or symptoms of heart failure. This is essentially their study design that may be a little bit more intuitive to look at as opposed to me just describing it. But essentially after an initial screen, these patients were randomized to either initial withdrawal of all of their GDMT, whether by reduction or complete cessation, again over 16 weeks, or continued treatment. once the 16-week time period was up and with a 6-month follow-up, the group that continued treatment essentially went to the reduction and cessation side of the GDMT to again just increase the power of the study because of the low population base. In terms of the results, so the relapse rate was alarmingly high. So 40% of patients did relapse within 6 months after stopping GDMT. And if largely these patients were asymptomatic, but for the most part, they used an EF or biomarker response to relapse. And 50% of these patients did need to restart their therapy for those reasons. The relapse largely was rapid, so generally occurred within weeks to a few months of withdrawal, whereas the continuation group, again, initially stayed stable, but when they later crossed over and were now in the withdrawal group, they also had a similar relapse pattern. In terms of the nature of the relapse pattern, so most were, again, asymptomatic ejection fraction drops or biomarker rises that was caught with sort of vigilant monitoring. And then 85% of those that did relapse regained an ejection fraction greater than 50% after restarting therapy, which again is important to note as it does suggest that if relapse is caught early, there is reversibility. The implication with all of this is that stopping all heart failure meds may lead to frequent recurrence and relapse of dysfunction, even in these recovered cardiomyopathy patients. And full dose GDMT essentially is recommended to continue indefinitely in these patients as a result. Now, again, there are obviously some limitations to the study. It's a small sample size, of course, with only 51 patients. So the statistical power and generalizability isn't quite there. On top of that, of course, as we mentioned, these are essentially already very, very low risk patients. And the fact that they were already relapsing isn't the greatest sign. This is a single center design, so it was just done in a single UK center, which again, in the context of a more diverse population may not be overly generalizable. And there was only a short follow-up duration, as well as, of course, lack of blinding, noting that this was open label. The other thing to note is that this study also looked at the withdrawal of all GDMT essentially simultaneously, which may not necessarily reflect real-world tapering strategies or more or less partial de-escalation scenarios. So I wouldn't necessarily say that this trial in itself is an end-all be-all in terms of deciding whether or not de-escalation of therapy is something that we absolutely shouldn't do. Now, another interesting sort of note about the study is that they did do a 5-year extension or 5-year follow-up of these patients. So after the initial TRED-HF, these patients were advised to resume their GDMT, and they were looking at how they actually fared long-term over 5 years. Now, even with most of these patients back on therapy, relapse actually continued to occur. By 5 years, 43% either had recurrent relapse or new relapse episodes. And many of these late relapses occurred despite these patients being on heart failure therapy. Now, this was partly due to not everyone being fully optimized during the follow-up period. And some actually had reduced intensity of therapy over time in quotes, the real world. So they may have started on actually higher doses of their GDMT prior to TRED-HF, and they never quite reached their sort of target GDMT or GDMT that they were on before, which again may be a reason why these patients didn't do as well. And again, just bottom line of this, this sort of observational component is that relapse of LV dysfunction can happen years after even initial recovery, which again likely means that these patients need to be vigilantly monitored for relapse even once they do improve their ejection fraction, and particularly if we're planning on de-escalating therapy. Now, one thing that I do want to talk about is the concept of recovery versus remission. So with regards to heart failure with improved ejection fraction, this, for the most part, is something that that is likely to be considered more remission, in that the heart may have improved function, but the underlying pathology is still present, and it still harbors some disease that predisposed it to the initial heart failure with reduced ejection fraction. There are likely some persistent changes present, and a lot of studies do show that these patients do have ongoing neurohormonal activation, which predispose them to relapsing even once they may be better from an ejection fraction perspective. This can be, again, seen with even just elevated baseline NT-proBNP level and other sort of microscopic myocardial changes, even if their ejection fraction, again, remains normal. Now, with regards to trigger, a recovered heart, again, noting that they likely have these baseline abnormalities, can still decompensate with certain stressors or triggers, for example, ischemia or a recurrence of an original trigger, for example, Takotsubo, and if they have another stress cardiomyopathy event. And some of these patients, even if they do have a recovered ejection fraction, may still have limited cardiac reserve, where these triggers and stressors cause them to decompensate in a way that you wouldn't expect if their cardiac function was entirely normal.
Attention, code white, 15 cardinal Carter South, OB-GYN, attention, code white, 15
we're just going to let the announcement go.
OB-GYN, attention, code white, 15 cardinal Carter South, OB-GYN. Attention, code white capsule. Attention, code white capsule. Attention, code white capsule.
So one thing to note is when we do talk about heart failure with improved EF, we are, of course, talking about ejection fraction, and there are limitations to ejection fraction that we need to consider if we're considering de-escalating therapy, because presumably their heart function is quote unquote normal. Now, EF is obviously a crude measurement, and it measures pump function, but can miss subtle dysfunction. And a normal ejection fraction, as we've been alluding to, doesn't necessarily guarantee that the myocardium is entirely normal and healthy. The other thing about ejection fraction is that it is load dependent and can improve with reduced afterload or favorable remodeling. And a lot of the goal-directed medical therapy that we're using does essentially affect how much load is exerted on the heart. So by reducing our GDMT, our EF theoretically should alter as well. One other thing to note that we've again also been talking about is that these are all essentially arbitrary cutoffs. A patient, for example, with an EF of 45% may still have considerable pathology, though we only really consider that as maybe mild dysfunction. And the criteria for improved EF doesn't necessarily take that into account. And then the other thing to note is with regards to normalization versus simply optimization. So with heart failure with improved EF, the definition again is a strict focus on ejection fraction, improved more than 10% to greater than 40%. But again, these patients may or still have still a normal ejection fraction, which is generally over 55%. So again, these patients don't necessarily have truly normal ejection fraction. And the other thing about measuring ejection fraction is that there are certain echo limitations that EF doesn't directly measure with regards to strain or fibrosis that we may require other imaging modalities to investigate. So one thing that we can do with our echo studies is measuring GLS, which or global longitudinal strain, which is a echo measure of myocardial deformation. And many of these heart failure with improved EF patients actually do have residual reduced GLS despite a normal ejection fraction, which again lets us know that even though these patients may have improved ejection fraction and sometimes even normal ejection fraction, their GLS or strain patterns may still be abnormal, in which case their myocardial reserve is likely affected. In one registry, they actually looked at GLS as an independent predictor of ejection fraction relapse. And it was noted that patients with poorer strain were more likely to relapse or deteriorate again compared to those that had normal strain. And with regards to diastolic function, again, ejection fraction does not necessarily reflect the diastology of the heart. So it's another factor to consider if we're simply looking at ejection fraction as a marker of improvement. And then finally, improved EF also doesn't mean complete reversal of remodeling. These patients may still have an enlarged left ventricle or elevated EE prime, which indicate incomplete recovery, which is why EF, again, in isolation, may not be the marker we should be looking at if we're considering de-escalation. So what do we recommend? Well, these patients likely require more advanced imaging. So MRI, for example, offers tissue characterization, and the indication of residual scar or LGE may indicate that these patients have fibrosis even after their ejection fraction improves. And again, these patients themselves may be the ones that are more likely to relapse or less likely to do well with de-escalation. MRI also is able to quantify extracellular volume and detect ongoing inflammation or fibrosis that, again, our typical echocardiography cannot. And persistent fibrosis on MRI also correlates with higher relapse risk for these reasons. PET imaging can also be done in select cases, for example, in investigating sarcoidosis or myocarditis to assess inflammation. If inflammation appears to be completely resolved, there may be lower relapse risk, noting that the underlying etiology is fixed. Whereas if low-level inflammation remains, they may regress if therapy is withdrawn. Again, one thing to note is that normal advanced imaging may equal potential true recovery, but any abnormal findings with these more advanced imaging compared to echocardiography likely means they're more likely to have remission. One other marker that we've been talking about is NT-proBNP, which is our go-to sort of barometer in terms of assessing wall stress and underlying cardiomyopathy. Even in patients with heart failure with improved ejection fraction, patients often do have elevated NT-proBNP compared to their healthy counterparts, even if they're asymptomatic and not in clinical heart failure. And persistent elevation of NT-proBNP likely suggests residual hemodynamic stress or volume overload that, again, may indicate that these patients aren't entirely adequate for withdrawal or de-escalation of therapy. In terms of prognostic value, in a certain cohort, they looked at patients with higher baseline NT-proBNP compared to those with lower initial NT-proBNP, and it appeared to be a strong predictor of future adverse cardiovascular events despite a recovery in ejection fraction and isolation. So all that to say, it should be used as a surveillance tool and monitoring these patients with regards to suitability for potential de-escalation or monitoring for potential signs of relapse. There are other markers, of course, that we can look at, including troponin, uric acid, GAL3, ST3 that have roles, but NT-proBNP appears to be the most established. Now, when we talked about the TREAD-HF trial, they did this study on patients that were essentially best case scenario. And although there were some limitations of that study that, I wouldn't necessarily say makes de-escalation impossible. If we were to ever consider de-escalating therapy, these should again be done in the lowest risk patients. These include patients that have complete EF recovery, so patients that do have an EF of greater than 50%, even though the ACC recognizes heart failure with improved EF as an EF greater than 40%. They should also have normal cardiac size and function, so normal end diastolic volumes that are back to the normal range. And as we alluded to, they should have normal NT-proBNP, as higher BNP levels do likely indicate that they have underlying hemodynamic stressors. They should be NYHA class 1 and no clinical heart failure symptoms. And then with advanced imaging, whether with PET or MRI, show no significant scar or fibrosis, as well as have no major arrhythmias on ECG. And then, of course, if there is an underlying cause or etiology, the precipitant should be resolved. So whether it's no ongoing ischemia and complete revascularization, or treatment of any tachyarrhythmias with ablation or medical therapy. Now, with current guidelines, with regards to GDMT, we have our, ACE, ARB, RNAs, beta blockers, MRA, SGLT2 inhibitors, essentially the core four for HFrEF. Guidelines essentially say that we should continue these indefinitely. And a lot of this is based largely on the TREAD-HF results and expert consensus. So looking at the 2022 ACC or HAA guidelines, it is a class 1 recommendation that that GDMT should be continued even in patients who are asymptomatic. And there's no clear recommendation on the CCS or ESC guidelines about this thus far, though again, it's kind of implied the same. So again, none of this is really clear cut because we are making, there is a lot of gray area in terms of what we can do. So there does remain some controversy as to whether all heart failure with improved EF truly need to be on lifelong full dose therapy. It seems like that's probably the safest and most conservative approach, and it's the approach that is recommended by guidelines. But is this something that can potentially change in the future? It's definitely food for thought, largely because there are other things to consider. From a patient perspective, lifelong polypharmacy can be burdensome, both in terms of cost as well as side effects. These aren't necessarily entirely benign drugs. They can cause, renal issues, hypotension, other side effects, reduction in quality of life. For example, fatigue from beta blockers. And it would be something that, if de-escalation is possible, it would be something that could improve the quality of life of patients if they were to stay well from a heart failure perspective. Now, I did want to switch gears a little bit and talk about some specific etiologies um, of HFrEF and their eventual improvement in ejection fraction. Just to talk a little bit about certain clinical scenarios that we do see. And again, where questions can be raised as to whether de-escalation is potentially reasonable, even though guidelines may recommend otherwise. So one of which is peripartum cardiomyopathy. So the definition of peripartum cardiomyopathy is a reduction in ejection fraction that occurs essentially within the last month of pregnancy or 5 months postpartum with any other unidentifiable cause. It's usually a form of non-ischemic cardiomyopathy that we relate to pregnancy. Now, in terms of recovery rates, it's highly variable, but generally 35 to 72% of these patients do have a recovery in ejection fraction, and they largely recover within the first 3 to 6 months after delivery. Others may unfortunately experience persistent dysfunction. There is a predictive model by the ESC that was developed to estimate the chance of EF recovery. And these include, our typical factors, including baseline ejection fraction, severity, among others. And then with regards to prognosis, so it appears that those that do recover their ejection fraction have good short-term outcomes. And even with recovered postpartum cardiomyopathy patients, they still remain at high risk of relapse, especially under stress, whether that's another trigger or subsequent pregnancy. Now, what to do with sort of your GDMT in these patients? So again, this is where the controversy arises. There have been small studies that do show a cautious possibility of de-escalating GDMT. These are very, very small studies. So there was one by Emos et al. In 2006 with an N of 50 that showed that stopping beta blocker and ACE inhibitor in recovered peripartum cardiomyopathy patients did show no ejection fraction drop at 2.5 years. And then another study that was done in 2018 tapered meds over 3 years and showed that essentially all but one of these patients were relapse-free at 8 years time. Now, again, these are small retrospective studies, but it does bring up a debate that maybe more trials need to be done to look at the de-escalation of GDMT in very specific cases. Now, we also have chemotherapy-induced cardiomyopathy, and there are actually two different paradigms. So there's type 1 and type 2 cardiotoxicity, type 1 being irreversible structural injury, and these are predominantly caused by anthracycline-induced cardiomyopathy. So, for example, doxorubicin. Recovery, if they occurs, is usually partial, but relapse risk in these relapse risk is largely very high due to more permanent damage to the myocardium. Type 2 cardiotoxicity is usually related to trastuzumab-induced myocardial dysfunction, and these don't necessarily cause structural destruction, and because of this, they're actually largely reversible. So HER2 or trastuzumab cardiomyopathy tend to show high rates of ejection fraction recovery after stopping the drug. There have been studies in the past, again, small sort of cohort studies with 38 patients on this chemotherapy agent that showed recovery of ejection fraction within 1 to 2 months. And these patients these patients were actually re-challenged with trastuzumab with heart failure meds on board and had minimal recurrence of dysfunction. So it seems like if caught early and on appropriate therapy, trastuzumab does not necessarily have to be stopped indefinitely. With regards to management, having said all that, is If we believe this is anthracycline cardiomyopathy, we would treat this as chronic dilated cardiomyopathy, and we need to continue heart failure meds essentially indefinitely. There really is no safe withdrawal due to largely more irreversible permanent damage to the myocardium. Whereas if it's more HER2 related cardiotoxicity, there is evidence that ejection fraction may recover because it does not cause as much permanent damage. And there are some oncologic strategies that use permissive cardiotoxicity if these chemotherapy agents are used in conjunction with appropriate goal-directed medical therapy. There are some ongoing trials that look at these scenarios, such as COP-RCT, which look at, again, heart failure meds and recovered chemocardiomyopathy. Another trial called HER-SAFE, where they look at withdrawal of heart failure therapy and recovered HER2 cardiomyopathy, and then STOP-MED, which looked at stopping medications and normalized cancer therapy cardiomyopathy. So a few trials in place that will help us sort of answer this question, looking at this specific patient population. Now, another etiology to consider is tachycardia-induced cardiomyopathy, where the mechanism is generally prolonged high heart rates, whether it's chronic AFib with rapid ventricular response, flutter, SVT, or frequent PVCs. This in itself can cause systolic dysfunction, or what we call tachycardia-induced cardiomyopathy. Theoretically, if the arrhythmia is treated, the cardiomyopathy should improve and resolve. And the longer the tachyarrhythmia stays at bay, the less likely the cardiomyopathy should recur. The treatment of this is, again, treating the underlying cause. So whether it's catheter ablation or aggressive rhythm or rate control is first line to actually eliminate the arrhythmia. This has been shown in itself to show ejection fraction recovery within months in many cases. Now, unfortunately, there still remains a relapse risk even after the arrhythmia is fixed and the ejection fraction normalizes. So one study with 188 patients did show that 47% of patients experience heart failure relapse in this retrospective study. Often this is due to arrhythmia recurrence or other triggers, and permanent changes such as fibrosis from the tachycardia may remain, which again sort of goes back to more advanced imaging to make sure that these patients do have underlying sort of normal myocardium. They don't have the fibrosis or scarring that may predispose them to relapse or recurrence. The one thing to note is that these patients, when they did continue heart failure medications, whether it was beta blockers or RAS inhibitors, the relapse risk was lower, which again suggests that ongoing therapy is likely protective. So in the case of tachycardia-induced cardiomyopathy, the evidence thus far remains that even if we treat the underlying etiology with ablation or aggressive rhythm control, these patients should likely stay on GDMT indefinitely due to these underlying changes that likely persist. Now, there is an ongoing trial called the WEAN-HF trial, which is looking at heart failure medication withdrawal in recovered tachyarrhythmia-induced heart failure. The study that I mentioned previously was more of a retrospective cohort study. Another smaller study is also being done called Withdraw-AF, which does have some preliminary results showing that greater than 90% of AFib-related cardiomyopathy patients did remain well off medications at the 6-month mark if their AFib was well controlled and if MRI monitoring was used. This is still underway, but it does seem promising, though again, they are using advanced imaging in conjunction with regards to determining the appropriateness for weaning GDMT. Now, myocarditis is another somewhat reversible cause of cardiomyopathy that we often get questions about in terms of continuing or de-escalating goal-directed medical therapy. So myocarditis in itself is inflammation of the myocardium, and that can be due to different etiologies, whether it's viral or autoimmune, and it can cause acute heart failure. In many cases, treating the underlying cause does lead to full recovery. However, a subset do still progress to dilated chronic cardiomyopathy. Now, looking at uncomplicated versus complicated myocarditis, 75% of patients with an uncomplicated course, so those that aren't fulminant or persistent myocarditis that don't require ICU level care or don't have severe heart failure, tend to maintain a preserved ejection fraction or may have more transient dysfunction that resolves quickly. These patients may not even require, or these patients may not require long-term heart failure therapy once recovered. The patients with more complicated myocarditis with more significant drops in LV dysfunction that require GDMT, they are also thought to have a more, or historically thought to have a higher likelihood of complete recovery than the more subacute forms, especially once we treat the underlying cause. However, if they do recover, or sorry, if they recover, they may safely be able to come off therapy in the long run. However, again, this is also contingent on them being low-risk patients at the end of all of this. So what are their BNP levels? What are their MRI imaging profiles? Do they have underlying fibrosis? And things like that. Now, again, the current understanding or sort of current recommendations in these cases is that de-escalating therapy is probably not recommended, as relapse and late deterioration can still occur, especially if ongoing inflammation or viral persistence is a concern. In terms of management, again, it kind of depends on what the risk profile of these patients are. Typically, these patients do continue heart failure medications for at least a year, even after recovery. And then with advanced imaging, if again, they're low risk, there's no scar, no inflammation, their underlying triggers are dealt with, and there's no concern for recurrence, then tapering immunosuppressives and heart failure meds may be considered, but again, there's no real consensus, and this is a very, again, gray area in which we deal with on a case-by-case basis. Again, if we're going off of the sort of class 1 guidelines from the ACC, they should sort of they should continue these medications indefinitely, but it is an area of research in the future. And then I did want to talk about Takotsubo as well, one that we see with more of an acute reduction in ejection fraction. These patients tend to have a specific trigger, but their ejection fraction tends to recover within days to weeks. Usually it's considered reversible, and there usually isn't any permanent damage. And for the most part, their short and long-term mortality is similar to the general population if there's no delay in recovery. What we mean by that is if recovery is not prolonged, so not more than 2 weeks, their prognosis is generally quite well. However, those that take significant time to recover, so more than 2 weeks, they likely have some underlying pathology that would make them more predisposed to, again, having an abnormal heart with a higher chance of relapse or recurrence. Again, there's no proven therapy to prevent recurrence. We sometimes give them beta blockers to prevent the sympathetic drive and reduce recurrence. Generally, long-term heart failure therapy isn't required once EF normalizes, but each recurrence risk, again, should be assessed on an individual basis. Again, looking at advanced imaging, recurrence of stressors, and again, whether or not this was a short period of recovery or whether this was more of a prolonged recovery. Alcohol-related heart failure is something we see as well. So excessive alcohol can cause dilated cardiomyopathy. And again, the thinking is that if a patient is able to achieve abstinence without underlying cardiomyopathy, then theoretically, these patients should have very low relapse or recurrence of heart failure. Sometimes we may keep them on low dose of ACE inhibitors or beta blockers as an insurance, because again, you can never predict when these patients may go back to consuming alcohol in any capacity. Again, there's no clear guideline, but it's again more so done on a case-by-case basis. And then finally, I did want to talk about ICD in these patients. So generally, these patients, or a large majority of these patients, already have primary prevention ICDs if their ejection fraction is less than 35%. The benefits of the ICD, of course, remains the same. If they do have underlying cardiomyopathy, fibrosis, scar, they are at a higher risk of arrhythmia compared to the general population, even if their ejection fraction improves. And they may get appropriate shocks if they do have any, ventricular arrhythmia. The risk, of course, there are some downsides, namely psychological, physical, and procedural. So psychological, again, the anxiety about shocks and not knowing when they may get one. The physical complications of, lead failure, infections, if generator changes are needed. None of these are entirely benign, so they may need additional procedures if we do decide to keep them with a functioning ICD for the rest of their lives, which again sort of goes into the more procedural complication. The thought right now is that for the most part, if their ejection fraction has normalized and their underlying cause has resolved, some clinicians may consider just deactivating their ICD or essentially having their ICD run its life course and not replacing the battery at the end of life. But again, this requires assessment on a case-by-case basis with EP consideration, patient preference, and again, the likelihood of them developing arrhythmias based off of their underlying cardiomyopathy and reason for ICD implantation. Now, we talked about some ongoing trials already, so I won't belabor the point, but the two that I did want to mention in addition was Bonfire, which is underway. This is a phase 3 trial that's looking at the withdrawal of beta blockers in heart failure with improved ejection fraction. And hopefully will show that if stopping beta blocker alone is non-inferior in terms of relapse. Another trial is actually TREAD-HF2, which is a pilot study that's looking at this, that's again looking at stepwise GDMT withdrawal. And it's going to be done in a way that's a little less dramatic than the initial TREAD-HF trial. So removing one class at a time. So whether that be MRA, then SGLT2 in these recovered dilated cardiomyopathy patients. And again, it's refining the protocol for partial de-escalation, which again is something to consider as opposed to complete de-escalation, which was the thought process behind TREAD-HF. We already talked about these, so I won't belabor the point. Again, in summary, the central controversy of heart failure with improved EF is this diagnosis a state that requires lifelong therapy, or can it be considered, cured in some cases? I mean, it seems like looking at the evidence, these patients are not necessarily cured, but there may be instances where low-risk patients and patients with specific etiologies may not necessarily need goal-directed medical therapy, but this is an area for further trials and studies before we can safely say that de-escalation is okay. The current evidence, of course, leads to continuing therapy for most. And since most of us are, fairly conservative in our approach, the safest thing to do at this point is likely continue goal-directed medical therapy until new evidence comes out that tells us that we can either de-escalate, whether partially or completely in the future. And again, depending on what their underlying etiology of their cardiomyopathy is. And these are some references, and I believe that's it. Thank you.
That's great. Thank you very much, Muizz, actually, for a very informative and comprehensive summary of this important topic. We have a few minutes for questions. Any questions for Muizz? So I guess maybe I'll start actually. So you actually talk about risk prediction for ejection fraction recovery in pericardium cardiomyopathy. I'm just wondering if you came across any kind of validated risk models taking into consideration the etiology. Obviously these are very heterogeneous patient populations, like alcohol-induced versus like tachycardia-induced versus myocarditis and so forth, any all chemotherapy. Any risk models that take into consideration that are kind of disease specific, kind of akin to oncology, where we can use them to kind of inform shared clinical decision making. Yeah, like in terms of predicting relapse.
Yeah, like I didn't come across, again, like I could have just missed it, but I didn't come across a sort of risk score or a criteria that could predict whether someone is more or less likely to relapse with de-escalation of therapy. I think again, a lot of this is based off of the risk profile in general. I'm not sure if there's a risk score that we can look at, but again, I think it's like looking at the big picture in terms of the risk profile of the patient. So I'm not sure if something does include all of this, but again, it sort of looks at whether or not we have like MRI imaging that shows underlying fibrosis, inflammation, and again, specific etiology and whatnot. But I'm not sure if you're asking this.
No, I'm not. Yeah, I was just asking. I think such models will be of interest, obviously, not just to kind of inform patients so that they can make choices, in view of uncertainty. Yeah, again, just like kind of oncology, but also might also inform future research in terms of selecting the patients who might be at high risk, in terms of who to study and maybe intermediate risk patients and so forth. So I think that would be interesting.
Yeah, like my understanding is like you kind of look at this as a case-by-case basis in terms of like their underlying etiology, and it's hard to, even if they have HFrEF, it's hard to group all of them together because they have HFrEF for different reasons. So it would be, I don't think it would necessarily be useful to combine all of these different patient populations.
Yeah. No, I agree. Actually, they are very heterogeneous. So I was just wondering whether there's anything that takes into consideration the etiology, and even, for example, considering the escalation as a risk factor to try to, kind of estimate actually, the pros and the cons, like the risk and the benefit. That's great. So Dr. Howard, actually, Dr. Robert Howard has a question.
Yes, it's a comment. So first, Muizz, great talk. My comment relates to echocardiography assessment of ejection fraction, which is in many of these studies was the model used. And just to remind people that, if most of us are not using 3D to get the ejection fraction, we're actually using the Simpson's rule, which uses only 2 views. So it excludes the anterior septum and the infralateral wall. So especially in cases like coronary artery disease, you can have significant wall motion abnormalities in those two segments and have normal wall motion or even hypernormal wall motion in the other segments, which results in ejection fraction that's, above 40% or even near normal, when actually if you did a 3D ejection fraction, it would be substantially lower. So just to put that in perspective, and I guess that would be especially true if you have somebody in the low 40s, you're sort of putting them in the improved group, but it's low 40s. The real ejection fraction may be significantly lower if you include those other two segments. So just something to be aware of.
Thank you for that. Yeah, useful.
Thanks. And I think HFimpEF actually had a question. Actually, he said, great talk. What about patients with valvular disease-induced heart failure, for example, like AS, mitral regurg, tricuspid regurg, and so forth?
Yeah, I think it would be similar sort of situation, case by case basis. A lot of the times with these valvular disease, I would suspect, again, just from my experience, again, I'm only C2, but usually they tend to have more chronic cardiomyopathy related to these changes as opposed to something that's more acute, like Takotsubo. So they tend to already have some underlying dysfunction that may be irreversible, in that prolonged aortic stenosis probably leads to some myocardial dysfunction that you're not getting with ejection fraction itself. So if we were to do an MRI on these patients, I suspect they probably have some degree of fibrosis or scarring. That may not necessarily make them as low risk for de-escalation. But again, I think it's case by case. And if we were considering them for de-escalation, we'd need to do additional advanced imaging, whether it's GLS, MRI, making sure their BNP is normalized and things like that, just to make sure that they're pristine from that perspective.
That's great, thanks. So yeah, I know that we are past the hour, so I think we've so I have put the link actually for the evaluation form. So I would like to remind everyone to please complete an evaluation form. So again, I would like to thank Muizz actually for an excellent presentation. Thank you, everyone.
Thank you.